And I'll repeat, welcome everyone to this webinar on occupational cancer and as an occupational disease. I will let Kurt Drive present the the speaker here and also lead the discussion afterwards. Please, Kurt.
Thank you, Ingrid, and thank you to Ingrid and Michelle for organizing ongoing activities with our so successful cost action. And this is showing that we're still all alive despite the pandemic. And a very warm welcome to all of you. Would be great to see you, meet you, hug you in person, but at least this is one way to stay in touch and keep working together for the better of public health in Europe and beyond. It is my great pleasure to introduce today Nicole Majery. You probably all know Nicole. She's the director of the Service de Santé au Travail Multisectoriel in Luxembourg. And as probably many of you will remember, this work within COST started when we reinitiated the Cancer Task Group in pre-pandemic times. So that was in, I believe, early 2020 when we met. And at that time, we had the idea to develop several different subgroups and with different focus. And this one on occupational cancer recognition across Europe was an idea that was brought up by Nicole and that found strong interest and support. We started working on that, but then the pandemic broke and we all then kind of changed gears and all focused on the COVID as an occupational disease, and which has now been more or less finalized, submitted, still waiting for comments from the reviewers. But essentially, the COVID kind of survey came first, but this one is really modeled along the same ideas. And all the details you will get now from Nicole, and we will have sufficient time for discussion afterwards. Thank you so much, and looking forward to Nicole's presentation. Please.
Thank you, Kurt, for the nice introduction. Thank you, all of you, for participating, and a good welcome from Luxembourg. So I will give you the results of our study. So we were focusing on occupational cancer recognition across Europe. Next one, please. Next one. Thank you. So we compared systems, policies, and practice all over the European countries regarding recognition of cancer as an occupational disease. So we will focus on different systems, national systems, on claims procedures, on criteria, on registers, on sentinel systems for occupational cancers, and also on benefits in case of recognition. Next one, please. So the method we use is the same that we have been using for the COVID. So we pilot tested an online questionnaire, and which was implemented with RedCap. And then after the adaptations from the participants in this pilot study, a link was sent to experts of the European countries within our Omega network. Next one. So the participating countries you have here in yellow. So as you see, we have some big European countries that had not yet participated. And after this presentation, we would be happy if we will have some more answers from countries like Spain, UK, etc. So to be more complete in our survey. Next one, please. So the first questions we asked, what is the system you have in your country? So you have in yellow the countries that have only a list system, and you have in pink the countries with an open system only, and then in blue, which is the majority, who have both a list system, but a claim can be introduced in an open system if the disease is not on the list. And then you have the specific situation of the Netherlands. So they have a system without list and no open system. So it is a little bit special and a little bit different from the general approach in the other European countries. It is more based in their country on cancer prevention than on cancer recognition and claims. Next one, please. So first of all, we asked the question about carcinogens, and we wanted to know, is there a specific part in the lists? So for those countries who have lists, is there a specific part dedicated to occupational cancers? And you see here 5 countries where that is the case. And then you have the other possibility to have it related to risk. So related to asbestos, you can have mesothelioma as a cancer, or you can have asbestos as a risk and giving cancer. So, and then you have the countries who have both. We have some cancers that are taken into account in the list, and for the other part, it is risk dependent and carcinogen dependent. And that is the most part of those who have responded. Next one, please. So then we asked also, what is your classification? On what kind of list you agreed on? And then you have first of those who agree on the IARC monographs, which is 5 countries in Europe. Then you have one who is only based on the European directive, which is Moldavia. And then we have the most of the countries have a national authority decision about what is put on the list and what is not put on the list. Next one, please. So then we wanted to know who has the right to file a claim for recognition of an occupational disease. You have countries where it's only the occupational health physician, like Bosnia and Herzegovina, Greece, Serbia, and Slovenia. Then you have Italy, where it is either the occupational health physician or the general practitioner. And then you have the countries where it's also an oncologist. And you have those like Germany and Hungary, where any physician can claim for an occupational cancer recognition. Next one, please. And then you have some specific procedures that has been mentioned in the questionnaire. So like Romania, where you can have a report by a physician, and then there is an exposure investigation by an occupational health physician of the public health authority to confirm the nature of occupational, if it is an occupational cancer. In Latvia, you have a medical commission for that. And in Turkey, you have a specialist physician of an authorized health institute, and you must have a signature by an hospital's health council to have the right to declare. In Estonia, you have an expertise commission of a Center of Occupational Diseases and also the North Estonia Medical Center. In Greece, you have doctors of the national insurance that can consider documentation related to exposure. Next one, please. And then you have in Norway, one before. Yes, in Norway, you have the patient that can claim compensation from the national insurance. And then they ask, so it can be the national one or a private insurance company, and they ask for specialist statements, both regarding the diagnosis and the assessment of a causal relationship. And they may ask the employer about to have information about exposure. In some countries, the employer can claim, like Denmark, Finland, France, Greece, Slovenia, Sweden, and Switzerland. And you have those where the worker can claim. And then you have Switzerland and Finland. There, the employer can also claim, but they must have the authorization of the employee. And in France, the family can also claim after the death of the worker. Next one, please. So then for criteria, are there specific criteria, or is an exposure sufficient to have to fulfill the criteria for recognition? And then you have countries where you have no specific criteria. You have like Bosnia-Herzegovina, France, Latvia, and Serbia, where you have the criteria of duration of exposure. In Romania, they can also ask for measurement of exposure. And in Germany, for example, it differs. It depends on the occupational cancer. So it can be like 5 years for asbestos exposure or BRP years. So it depends really on the cancer. And then you have those who have a level of exposure and duration. And that is Belgium, Denmark, Estonia, Finland, Germany, Italy, Slovenia, Switzerland, and Turkey. And then you have France, where we have, it is task specific. So if you have using a machine that is cutting asbestos, then you have it's a task can give you the exposure. Then you have Switzerland, where they ask for relevance of association between exposure and disease. In Finland, they use a guideline, so an expert guideline. And in Turkey, which is very interesting, is also considered the interval between the end of exposure and the diagnosis of the disease. Next one, please. Then we ask for the competing role of personal habits. So in some countries, they are considered. In Germany, for example, they are not considered if the exposure criteria are met. So then it doesn't depend if you are a smoker or non-smoker, for example, in case of lung cancer after asbestos exposure. In Serbia, in some spaces, smoking habits are considered, like in lung cancer. And in France, it depends on who is giving the advice. So if the Comité régional de reconnaissance des maladies professionnelles is required to give an advice, then always the personal habits are considered. Next one, please. So then the level of exposure. So who is assessing the level of exposure? So Italy, Estonia, and Latvia, it is the employer. In Denmark and Turkey, you have the employer and the employee together. In France, it depends. If it is cancer that is on the list system, then the national authority has defined specific criteria, and it is the National Health Insurance Fund which gives guidelines for the regional funds and the physician advising the caisse primaire d'assurance maladie at the departmental or the regional level are giving advice. In the open system, it is the Comité régional de reconnaissance des maladies professionnelles which has the responsibility of the level consideration. In Switzerland, it is the SUVA, which is the Caisse nationale suisse d'assurance en cas d'accident. So also an injury insurance company. Next one, please. In Hungary, so it is at the regional government, the Occupational Health and Safety Inspection Body, who has the authority to carry out inspections at the workplace to provide evidence, and also the occupational department in the National Public Health Center, which is an expert committee. In Bosnia-Herzegovina, Denmark, and Finland, it is the responsibility of the occupational physicians. In Romania, there is the Health and Safety Department in general. In Sweden, it is an occupational hygienist. And in the Netherlands, there is a committee of employers, employees, and experts. Next one, please. So what about the employers' registers that are considered in the EU directive? So in Belgium, Moldavia, Romania, Serbia, Slovenia, Sweden, and Latvia, there is a conservation of 40 years. And in case of liquidation of a company, they are stored according to the requirements in the laws and regulation of storage of archival documents. In Luxembourg, we have also a conservation for 40 years. And the employer, if he sees his activity, has to transmit the list to the Ministry of Health. And the data on the patients, on the workers, they are conserved in the medical files of the concerned occupational health services. In Hungary, when the worker leaves, the data are stored by the occupational health services contracted by the former employer, and there they are conserved for 50 years. In Norway, the conservation is even longer. It is 60 years, and it is by the former employer in case of change. And the register cannot be destroyed without the permission of the Norwegian Labour Inspection Authority. So that is the only country where I was informed that there must be an authorization to destroy the document. In the others, there is only a conservation duration that is considered, but nobody has to give the authority to destroy. So in case of company seizes, the registers in Norway are also transferred and must be available to the Norwegian Labour Inspection. In Greece, the employee has the right to take with him the booklets with his results and also the biological indices. In Turkey, there is also conservation for 40 years. Next one, please. So national registers for exposure, there are only a few. And in Finland, it is under the responsibility of the Finnish Institute of Occupational Health. In Germany, it is the ODIN, and which is at the insurance company, the DGUV. Kurt perhaps can give us more information on that later on. In Hungary, there is a national register, but I have no further information about it. And in Italy, it is the INAIL, which is also the National Authority Against Injuries at Work, who is responsible for it. So I think we have, afterwards, we have a little bit to consider and to ask these different countries to have more explanation about these registers and about how it works. Next one, please. So the Sentinel system for occupational diseases or occupational cancers, there are some countries who have an occupational central system for diseases in general, like in Bosnia-Herzegovina, where the University Clinic of Occupational Pathology and Toxicology, who is responsible for it. In Belgium, it is the FEDRIS, which is a federal agency for professional risks. You have a system in Estonia. In France, it is ANSES, which is the Agency for Food, Environmental and Occupational Health and Safety. In Germany is this GVS, Gesundheitsvorsorge, so prevention for health. In Italy, it is the INAIL, so which is also this National Insurance Against Injuries at Work, and also a regional authority. In Norway, it is the Norwegian Labour Inspection, and in Sweden, the Swedish Work Environment Authority. And in Turkey, there is a system, but I have no information further on it. In Italy, this is the only country who has a Sentinel system specific for occupational cancers, but I have no information also about it. So the same remark for the national registers afterwards to look a little bit how it works and what is the system exactly. Next one, please. Now the benefits. So when you look at so we have asked about treatment costs, about rehabilitation costs, about sick leave, and about disability pension and pension for survivors. In most of the countries, it's a little bit similar. You have only two countries where there is no, sorry, it's too fast. Can you go back, please? No, back. Yes. So in Estonia and in the Netherlands, you have no compensation system. In Bosnia-Herzegovina, you have only sick leave and disability pension and pension for survivors. So no considering treatment costs or rehabilitation costs. But in the other countries, it is the same. In Sweden, you have only the treatment costs. So there are also differences here in between the countries, but in general, it is for most of the countries, it is the same system. Next one, please. Then we have asked a little bit for claims. And so we have, when we look here, we have asked the reference here, the number of claims and the number of recognized occupational cancers. And there you see that there are big differences. When you consider, for example, Italy, where you have 2,643 claims, Italy is, when you compare this to Slovenia, Italy is 30 times has much more inhabitants, but you have in Slovenia, you have 88 times less claims that are considered. When you compare on the other side, Belgium to Italy, so Belgium is 5 times less inhabitants, and you have 8.5 less claims. So there are big differences about claims in the countries who had responded for this specific question. So really big differences about it is considered in practice. Next one. So I come to my conclusions. So despite an EU directive on carcinogens, the approaches are quite different within the countries regarding criteria for recognition. Except in Bosnia-Herzegovina, Estonia, and the Netherlands, the benefits are similar after recognition. And for the Sentinel system, only Italy has a specific one regarding carcinogen exposure. Next one, please. So for the future, so we wanted to complete our data from the countries who are missing on this list. And we want also to collect, as said before, we wanted to collect information about these national registers. And therefore, and also we have asking us if we shouldn't plan qualitative comparisons, for example, asbestos and lung cancer, that considering the different approaches by countries, the exposure criteria, the latency, the smoking habits, and the decision process, and to do another study on this. And also we could include case studies on quantitative comparisons across countries, for example, again, the asbestos-related lung cancer, and how many are in national registers versus how many claims, and also versus how many recognized cancers, and versus the global burden of the disease. So I have only to thank you again, to thank you for, next one please, to thank you for the participation for those who had participated in the pilot study, and also for those who had responded to the questionnaire or who had a phone call with me to collect the data. Thank you so much, and I am available for questions.
Thank you so much, Nicole, for a very comprehensive presentation, but also hopefully stimulating additional interest in perhaps some participating now who have not yet submitted their data, and follow the good kind of example of Michelle Turner, who immediately says, oh, Spain is missing. We have certainly to make efforts and include something. Unfortunately, same applies also for Germany. I realized that there are some important gaps, for example, about numbers of recognized occupational diseases, etc. But I mean, Nicole had a very nice summary, and there's many things probably to discuss. So I would first like to take any questions, suggestions, etc. from the audience. Please show your hand and then open your microphone. I don't see any questions so far.
I have a question. I'm Francesca.
Please go ahead.
Hello, sorry, but I think that I have a new computer, but probably there isn't the camera. Sorry, thank you. Thank you very much for the presentation, your presentation. I would like to point out something about Italy. because for treatment, treatment for cancer in Italy is covered by the national insurance system. That means that it is normally not covered by the health, by the insurance for workers. But what is not covered from health insurance system will be covered from the insurance system for workers. So definitely, I will put a tick on the coverage of treatment for cancer, occupational cancer in Italy, because all people have the complete treatment for cancer, both if it's occupational or not occupational. But if the national system didn't cover something about an occupational cancer or an occupational disease, the insurance that is INAIL for occupational disease covered all the extra things to do.
Thank you, Francesca. That is indeed an excellent point, because if you would only go by the table in terms of which benefits are covered, the Netherlands would look very bad. They don't cover anything. However, I would say probably the coverage in the Netherlands is altogether better than in some countries which have some of these benefits from the occupational health system. I mean, Henk can tell us more about that because they don't have a specific system, but I think the overall coverage is good. In Germany, for example, it is the case that there are some out-of-pocket payments in the kind of general health insurance system that has ever been increased over the last 30 years for drugs and etc. Well, if you have a recognized occupational disease, including occupational cancer, you're entitled to the fullest and best treatment without any out-of-pocket payment. So the details are really important here, and I saw Henk turned on his video, so perhaps he wants to contribute something. Please, Henk.
You're right. So I told many times in Netherlands, irrespective if the course is occupational or non-occupational, you have the same benefits. So on a social security system. So it's quite right what Nicole and Koert was saying. But there's a small difference nowadays in the Netherlands. There is not a compensation, but a kind of offer to people who have some cancers and get once a time a financial benefit or about 20,000 euros. There's not a claim on the list, but it's the beginning of recognition that it could be by work. So I told Nicole by phone already, and later on we can specify it, but we don't have a list system. We have an open system, but the occupational physician can register it at our center, and that we report to Eurostat. And I had some suggestion also to Nicole. Eurostat has also now experimental data per country, and they give the data also about occupational cancer. So it could be also a nice source of the magnitude of the cancers.
Yeah, I think, we'll come back to many of your excellent points, but let's take Marina first. Marina, please.
Hello everybody, and thank you for the presentation. I also want to mention that we are somehow similar with the other countries, that in Romania the treatment is covered no matter if it's occupational or non-occupational, and there is only a rather small, at least much smaller than the Netherlands financial incentive for any occupational disease, not in particular for cancer, when it is recognized. But otherwise, there's no benefit, there's not different in treatments. They go to the public insurance and they are covered reasonably, at least not less, no more than others. That
Yeah, I
was
think this is
something
certainly
to
an important
specify.
dimension that we need to capture well in an upcoming manuscript, and I encourage each and all of you to really take a close look that we get the balance right. What I still find mind-boggling, I mean, this is across European EU countries with all the efforts of harmonization across the EU, even on paper, what the kind of regulations are. There is a huge variety when it comes to what kind of occupational cancers can in principle be recognized as occupational disease, etc. Then at the next level, there's a huge variation when it comes to in fact, the practice, just in terms of numbers that have been kind of recognized. And then there's the final, the kind of decisive level on what does it really mean to the worker who has an occupational cancer. Does it make a difference compared to the national system of health insurance, etc.? And what are all the other kind of benefits and regulations? And how do you get there in terms of recognition? I see, for example, in some countries, if we understood that your response is right, it's the employer who decides about the exposure level, which of course is potentially problematic if they then downplay the exposure to kind of avoid recognition and additional cost to the company. Ingrid, please.
Yes, thank you so much, Nicole. This is it's a huge work, I know, to collect all this information. And when you said the quote about this harmonization in EU, I came to think about. I know the Norwegian list. It came about because of the ILO. Had made a list of occupational diseases, and Norway ratified this convention, ILO convention. So this is not related to your work now, but I was wondering, does ILO have a role in this today?
I can briefly answer that I have been I think once or twice invited to their tripartite meetings where the discussion was about the list of occupational cancers. Essentially, when IARC had classified a few new carcinogens that are also prominent in the occupational setting, at the time we discussed, I believe it was wood dust and nasal cancer, and also formaldehyde and nasopharyngeal cancer. And this is then where I, as a scientist from the Art Monographs program, have the role as an observer. And it was then a discussion between the employees and the employers. And the employers just simply said, no, we don't accept the formaldehyde evidence, and so it will not be added. So this is somewhat political decision then, and I think it's not really up to date also in terms of regular updating. And but we have European kind of ideas that would probably be much closer, given that this is a comparison across European countries. We have the European directives, etc. I wonder if there are not any regulations, mechanisms that such EU regulations would then need to be implemented in national systems. Perhaps Elke Schneider would know something about that. Elke, sorry for asking you directly. No, okay. Anybody else? Question, response?
There is a question in the chat here from Antonio Derico.
You can read it.
Yeah. How might it be explained, the decision for different roles, for example, physicians and hygienists or other more detailed and mixed groups of work that are responsible to evaluate the process of recognition of occupational cancer among different countries? Do you have any idea? And is there any idea about which one can be the best option? Sorry, I cannot use my microphone. That's why he wrote in the chat.
Nicole, you want to take a first shot?
No, I have not really well understood it because my microphone was a little bit disturbed. So
okay, I can take. I think the main question is about the who has the right to file the claim, and there was a very kind of a huge variety again, and the kind of bottom line question is what do we think is the best option? And Antonio, I would think the best option is all of the above. Anybody that has a suspicion that any of a disease that he or she sees as a physician could have an occupational nature, they should they should file a claim file a claim for recognition of occupational cancer. That's at least what's written in the law in Germany, that everybody who has a kind of a supported suspicion. So you must have some idea that there is, say, an important exposure that can cause the disease in question. And in addition, because if the physician would not know, and the clinicians often have not a strong clue about these, and the worker may not have kind of a easy access to an occupational health physician in some countries, then there should also be the additional right that if the worker has a strong suspicion that it's of occupational nature, that the worker can also file a claim. I think this is essentially all physicians and the worker. That would be my answer here. Ingrid, you have your hand up.
Yeah, Nicole, do you want to add anything to what Kurt just said?
Yes, I was a little bit astonished about that the employer is claiming, because normally the employer is not supposed to know the diagnosis of his workers. So that was a little bit astonishing for me. So that the worker can claim, and then that afterwards there is, how to say, an advice from a specialist about exposure and relationship, so that the causality is given by either by a physician or by an hygienist. But that the employer is claiming, that was really little bit astonishing me. And there was really some countries where it is the case.
Yeah, I have also, I was thinking, should we make a recommendation based on this work? Are we ready to do that? What could be the next step?
I think my bottom line would be to really point out the huge kind of variations across Europe, with a certain need for better harmonization. In addition, then recognizing that some of these variations on paper may be even more extreme in practice, or maybe less extreme in practice. The first one was about the numbers kind of recognized. The second one was about the essential benefits, as pointed out by Henk and others. And then from there come up with, I would say, conclusions and suggestions. Hopefully this will then be heard by somebody at the EU. Wojciech, you have your hands up.
Okay, hello. First, I would like to really congratulate to Nicole for fantastic job she did. And the second, I would like to apologize that the Poland was not in the list. I didn't know how it's happened that we didn't participate in it. But of course, we are ready to contribute. And one of the major point is which is against the process of registering occupational cancer is a short survival for cancers like lung cancer. In Poland, it is usually not more than year, 2 years. And in that time, people are seeking treatment, not really compensation. And it is a very of a, I think, emotional time. And I think oncologists should be aware that some exposures might be related to lung cancer. This list is long, but I think the most important, of course, is asbestos and chrome and nickel, and then silica, which is more controversial, of course. But I think oncologists should advise the patient, because families don't know much. They think of he was a hard worker, he did a lot of work, he worked in the factory, there was fumes, so it may contribute, it may not. It is not really, I think, very. They usually are focused on obtaining the best possible treatment. So oncologists, I think, should be on the first line. In Poland, it is only occupational doctor may suspect disease, and this certification is based in regional institutions certification, and then is a long process of supporting the diagnosis, which means usually there is a company is asking about second opinion, and then the last on the list is a sanitary inspection, which certifies the exposure. So without them, we cannot do it. So in case of it, so this is, now we come to the second point, that information about exposure, which took place several years back, are not really available, because they were done by methods which are not reliable, or just were semi-qualitative or something like this. So thank you, and once more we'll be happy to contribute. Nicole.
Thank you, Wojciech. Most appreciated. And I think what you said is oncology first is perfectly fine, but I would still think all of the above should be somewhat included. I would have some more to say, and I'll come back to that later, but let me take first other hands. Zakia, please.
Thank you very much for the presentation. Hello, everybody. I was thinking about the part of the recommendation, because I think your work is very important about related to prevention. Why? Because these are the only way to put a link between cancer and exposure in the work world, because those figures that these insurance can raise are the only one, is a proxy of the cancer in the real world. So it's just a proxy, and it's just the high peak of the iceberg. So an harmonization of the rules to pick these figures is very important, not to underestimate the number of occupational cancers in Europe. So as long as we have those different rules, we can be sure that we do not have a right picture about cancer in Europe. This is my first point. The second point is that in a cancer register, it's not really, I cannot assume that the profession is collected. And even if it is collected, I'm not sure it is well collected. And using something like CTP 88 or a standardized way to collect profession. This is a second problem. Here is Switzerland, for example. The profession was collected in the register of cancer. Now it is not. There is a federal law that allows the register not to collect profession. So we have another problem about the source. So the source of coming from insurance is, for now, for me, like I see the situation, one of the best to have a proxy of this figure of occupational cancer. The third point was a little answer to Wojciech. Having been an hematologist before being an occupational physician, I can assure you that looking for the etiology, the why this person have a cancer is the least we can think about. the first thing and the only thing, and it's like an obsession, is curing the person, really. So when somebody comes just to write a little paper, administrative paper, saying leaving sick or something, we're completely out of the game. And we say, let's see with the secretary, she will give you some advice. You see? So I don't think this, perhaps if occupational physicians take the lead for this question, it can have, we can have an answer, but relying on other doctors, I don't think it's it can be really a solution. Thank you very much.
Yeah, Sakia, thank you for your enthusiasm about taking that forward. And from one of my former lives, I completely agree. One of my mentors, Professor Wojtowicz at the University of Gießen, he always said, the compensation of occupational cancer is a huge incentive to improve primary prevention. So it's not only for the individual worker and the family, it's also for primary prevention from tertiary prevention in general. The other point you mentioned on the oncologist, in yet another former life, I have also worked as an oncologist. And I know that indeed, the very first thing after they have been diagnosed with a cancer is why? Why me? And that's where the search for the causes starts. And so I think we need better training of oncologists to kind of make the links. And in Germany, since I believe the 80s now, or even earlier, it is a mandatory part that all future physicians, medical students have mandatory courses on occupational environmental medicine. And I've been teaching these at the University of Gießen, including the system of occupational diseases. Ingrid, is your hand still up?
Oh yeah, that was a new one. Yeah, I also thought about this, about people who get cancer. They think of getting treatment and not compensation. In Norway, the cancer registry send letters to people who are registered with certain cancers, lung cancer, mesothelioma, bladder cancer, and nasal cancer, informing that these are cancers that may be work related, and if they think it might be, they should contact the doctor about it. You are muted, Kurt.
That is most interesting. Is there any kind of a scientific workup of this kind of approach on how many additional occupational cancers were identified?
I think that's difficult. I know that Christina Kjærem wrote a report several years ago. She was the one who initiated this quite a few years ago, and but I'm not sure if someone has ever summed up the results. I don't think they can.
When writing the paper, I think this is keep it in mind. It can be an important consideration and contribution also for recommendations.
Yeah.
Okay. Who's next? Wojciech, you had your hands up again briefly, but
it is still left over. Okay, I will try to get rid of it.
Okay. No,
Okay,
it's no.
okay.
Okay.
I don't know. Yeah, maybe I will.
Okay. Any other kind of questions, suggestions? What I have in, yeah, Marina, please.
Yeah, me again. I would say that the recognition, yes, of course, it's important, but at the moment we had the diagnosis, everybody's fighting for survival. The only way to increase the recognition is the exposure and post-exposure follow-up and early diagnosis, because that's the moment when, I mean, if they are included in a surveillance plan at the moment the cancer either by a screening test or by acknowledging already the disease, they automatically will be entitled to be recognized. I mean, we have to be here a little bit more proactive than we are now. Now we are reacting, okay, sometimes when the patient claims the diagnosis, the occupational origin of the disease, we recognize them. But I don't think that that's the right way. How to do it? There are some good examples, as far as I know, in some countries where there is a certain follow-up after exposure, particularly for some occupational risk. And I think this should be somehow generalized as a good practice. Particularly now when we have rather good treatment, or anyway, much better treatment for lung cancer, for example. For bladder cancer is not extremely well, but still, if it's diagnosed early, the survival is much better. So it really makes sense to do it. We have guidelines for lung cancer for people that have smoked 30+ years now. In some countries, they got higher CT screening, but the ones that didn't smoke, didn't do this, and were just exposed to very aggressive hazards, respiratory hazards, they are not. So I think we should go both ways, not only on the oncology side, but also on the occupational medicine side.
Yeah, thank you, Marina, and Ferenc now.
Yes, thank you. Sorry, I do not have a camera, so that's why there's no video. I think that this occupational cancer issue is very well representing the problems with occupational diseases at all. It is like it has all the features that we have problems with occupational diseases. There's a long latency period usually, so people are not in that work, and an exposure cannot be verified many times, and also they are usually multi-causal, so it's very difficult to say whether it is an occupational disease or not. For example, in Hungary, you can say that it is or it is not. You cannot say that it is 35% occupational. And even if we could say, we may not be able to say the percentage. It's very difficult to estimate it. So it is this. First of all, I think we should decide what is the goal. I think that it is prevention, and then the focus should be put there. I am very much interested in estimating real figures, but even in the cases of mesothelioma, which are mostly asbestos related and thus occupational diseases, in Hungary you get 0 to 3 reports a year, while there in the National Cancer Register you have 70 to 100 persons annually. So this means that the entire health system is not ready to deal with these issues, and probably some sort of automated data collection could be an answer to find the real or estimations, or to get closer to the real figures.
Thank you, Ferenc. I mean, the whole kind of principle on how this is approached, for example, in Germany, where I know the system best, is that, of course, there is say, independent etiologic research of what is causing cancer. And then there's different systems in terms of workplace protection. There's, for example, the MAC committee for setting workplace limits. But when it comes to genotoxic carcinogens, then the threshold limit values are established by another kind of committee, which is tripartite, because then it's about the burden and to following a traffic light model that it should be below, say, 1 in 10,000 additional cases or 1 in 100,000 additional cases. And then it comes yet to the, and that's our topic here, the recognition of occupational cancer as an occupational disease. And that is yet another committee that sits at the Ministry of Labor and then decides which of these cancers can be included in the list. So even if something is decided by the German MAC as a group 1 carcinogen causing cancer in humans, it's not automatically on the list of occupational cancers. There, they follow the idea that, and that is now from the legal world, the probability of causation is above 50%. This concept has several kind of epidemiological and scientific shortcomings, but this has sometimes been used to say we need a relative risk of 2 for principal possibility to include it in the list, because then with the principle over the relative risk of 2, you would have a 50% probability that it's from this exposure. And this has long been kind of a rule of thumb. But then in the individual case, the situation is, of course, very different. And again, there in Germany, in the 80s, 90s, because of some of these issues, they developed more quantitative models, like following the fiber years or the BAP years that you would need for kind of exposure to be recognized as say, an asbestos-related lung cancer, unless you had other what's called bridging symptoms. So if a worker had, say, pleural plaques or asbestosis, then this was seen as kind of a proof of exposure, of substantial exposure, and then a ensuing lung cancer could be compensated. So there's lots of ideas behind it. Not all of these are really scientifically very sound, but in the end, I think the biggest problem, and I forgot who pointed it out, is really that to have access information about previous exposure in your kind of working life to the relevant carcinogens. And that's where it most often falls apart, at least in Germany. Any other points?
There is another message in the chat.
Okay.
Yeah.
From Joe. Hi all. I can ask Christina Gerheim where the notification system to patients of potentially occupational cancer stands today at the Cancer Registry of Norway. Yes, please do so, Joe, and all the best to Tina.
I will do so. I will ask her. I talk to her from time to time, so I didn't know about this actually. So it was it was very nice that Ingrid told me to. So I will check up.
I hope it's still
very interesting. Yeah, indeed.
Yeah.
Is there anybody, I'm looking at Damien, for example, who could tell us a bit more about what Nicole presented as sentinel systems? I have difficulties to imagine how these could work in terms of discovering new occupational causes of cancer. I know that at some point, not knowing if it's still active, it's not my expertise, the UK developed this word, which was for respiratory diseases as kind of a sentinel system. But is there anything as a sentinel system on cancer?
No, there's SARD for respiratory disease, EpiDerm for skin disease, which obviously includes skin cancer. There's one for general practitioners and a long-standing one for occupational physicians. They're all overseen by Marty van Tongeren at the University of Manchester. But I'm not aware I mean, the problem with the UK is that we don't even routinely collect occupation within our National Health Service. So there's almost a disincentive for doctors to follow up on cancer cases. And I don't think we get as many of the so-called classical observant physicians identifying clusters of cancers that come through oncology clinics that we used to do. But maybe that's good because there's not so many occurring. But we don't really have a proper structured system for identifying sentinel cases.
Yeah, I'm even having conceptual problems in how that could work. I mean, knowing all the problems that we have with kind of our epidemiological methods to kind of make causal inference about some exposures.
Yeah, cancer registries, some collect occupational data, but some don't. They're not mandated to collect it. It's very frustrating for researchers.
I mean, then think at the highest level, of course, the Scandinavians with their 5 countries and having the NOCA over many decades, they have at least then links to other databases, and every 10 years can get information about the occupation. But this is rarely kind of very informative as a sentinel system to identify new causes of cancer, because then you need to go from the chop to the gem, and then I mean, we have used these data and we see several of those here. Johnny is among the lead persons now, but I wouldn't see this as a sentinel system.
No. The one other thing that happens in the UK is that every 10 years or so, there is an occupational analysis of cancer registration data for those that are occupationally coded, but that's more of a hypothesis generating exercise.
Indeed, yeah, thanks for mentioning these. I find these useful. Yes, I remember. But again, it's not a sentinel, not what I would see as a sentinel system. I mean, Italy has a system for a national mesothelioma registry that is much kind of better in terms of epidemiology than the German registry, which is essentially with the pathologists. And I mean, this is a unique story, and it will probably not happen again. But using the mesothelioma registry, they observed an unusual increase of mesothelioma on Sicily, and found out that there was no evidence for occupational asbestos exposure. Further, they found out that this was more or less equally distributed between men and women, and was particularly among relatively young people with mesothelioma. And altogether, that led to the identification of fluoroadenine as a new occupational carcinogen. In that case, it was more environmental, but this is another fiber that's causing mesothelioma that was from a quarry on the slopes of the Etna. It's a fascinating story that we wrote up in one of the monographs. But again, this is, I wouldn't call this primarily a sentinel system. Wojciech, you're still muted if you're...
Yeah, we mentioned sentinel approach. What about surveillance of ex-workers? Do you find it useful? I mean, is a problem you face that in lung cancer, the surveillance with the focusing on early discovery was for a long time considered not to be really ethical, yes, because for short, no treatment available. However, I think things are changing. Lung cancer is more and more of a disease for which we can have an extension of life and have a better treatment. So what about covering asbestos workers or silica workers? Yes, this type of surveillance in order to early discover a cancer. We have in Poland a system for asbestos, which was developed, I think, mainly because to provide this asbestos workers with some kind of compensation and giving them possibilities to have a rehabilitation and so on. It was not primarily developed to discover a cancer, but asbestos was quite frequently discovered. Cancer, not so many, few cases of mesothelioma. But the issue is it worthwhile to do a surveillance of ex-workers?
I mean, the question is why you would do this, and I think you have different perspectives in your kind of comment. First of all, I think the screening for lung cancer and screening for occupational lung cancer has indeed, also in my opinion, been unethical, but not because of not having good treatment options, but because of the screening wasn't shown to be effective. That has dramatically changed since the ENLIST, the US trial, and also some of the European trials, including the Nelson from the Netherlands. And we are currently writing up a statement from the Collegium Ramazzini that occupational cancers should also be eligible for, let me put it different, occupational exposure to certain carcinogens should also make you eligible for screening for occupational cancer. This is something that's in the pipeline, probably coming out this year. It's pretty well advanced. But then surveillance is kind of something different than screening. And so I think screening would be of interest with some cautionary notes. I've always been a bit skeptical and changed more recently. And surveillance is, for example, if you look into those that have been previously exposed, and there is, for example, an audience system that in Germany that Nicole mentioned that guarantees you as a worker who have been exposed during their life, if you retire or change companies, that your post kind of exposure preventive examinations, how they are called, will be continued. So that is organized in that system. It's an organization system, essentially. Because that comes back to the latency also mentioned by one of you as a major problem. Some of the causal exposures may be decades in the past. I saw another hand, but I didn't want to stop anybody.
Yeah, I was going to put something in the chat. So, yeah, so John Cherry and I worked on something which would, the problem with former asbestos exposure, for former asbestos workers, say, for example, in the shipbuilding industry in the UK, is that once they stop working, they dissipate and become lost to follow-up very easily. So the incentive for identifying mesothelioma early, according to physicians in mesothelioma physicians in Glasgow, is to get them into clinical trials as early as possible with a view to improving, well, hopefully getting a cure, but improving quality of life and life expectancy of people who get mesothelioma. And John and I had the idea of trying to use people's past employment history as a means to identify people, perhaps using asbestos support groups and the like, to get them to come forward and in this case it was fairly high resolution MRI scans. So as you mentioned, the scanning technology has improved enormously in recent years. And so previously there was the issue of X-rays and even CT scans and the ionizing radiation dose, but that's, as I understand, it's less of an issue now with MRI scans. But we tried to get a research project on this topic going, but we weren't successful at the time. But it's probably still a valid research issue to follow up on. Maybe a European study might be more successful.
I mean, I mean, this is going in a slightly different direction, but I mean, the systems that have been used and shown to be effective for screening for lung cancer is low-dose spiral CT. So this is a kind of an advanced computed tomography, which has the additional important benefits to lower the exposure to ionizing radiation, because that is at least a concern if you go for annual kind of computed tomography. You're also exposed to additional carcinogens. I'd love to follow up with you offline, Damien, on the screening for mesothelioma. I have very strong opinion here that at the moment this is not warranted and not ethical, because we can't offer a better kind of treatment. I'm even worried, and I brought that up regularly in our kind of developing the statement on screening for the Collegium Ramazzini, that most of those who had been exposed and what we expect to see is asbestos. And if you screen asbestos workers, there is probably also a likelihood that you kind of inadvertently screen for mesothelioma. And for me, this even poses an ethical dilemma. But this is a very complicated domain, and let's discuss it offline.
Okay.
Any other? We still have, officially we have 19 minutes. Typically we go 30 minutes, so we're half time in regular overtime. Ingrid, do you want to?
Yeah, I added, I put Nicole's email address in the chat so that you can send her information or contact her if you have something you want to, some country information or some other information you would like to share.
And Nicole, and we will share with you additional kind of incentives to contribute your data. We'll contact you bilaterally for clarification of some of the issues, and then we'll prepare a first draft. And then please be very critical if we represent in the right way what we understood from your answers to the questions. And with this, let's be optimistic and hope that the manuscript can be circulated before the summer as a first draft for all your inputs. Nicole, you have the final word.
I have the final word, so I would like to thank you again, and I look forward to have some more information and to complete our data and to contribute to the first draft. So I have started to summarize what have been sent to me, and so you will hear from us when we are prepared.
Yeah, I would like to thank Nicole and Kurt first, but also all of you who have participated. I think this has been a very good webinar and a very good discussion, and important discussion, and thinking one step further, not finishing with this manuscript, but thinking what can be done next and what can we give our recommendations. I think that is very important. And also regarding prevention, that is also a very important point here. I would also like to ask if you have ideas for other webinars. We do not have a cost action active anymore, but we are still active. we don't get funding for a meeting, but we can still collaborate, and I think that is important, and hopefully we will get more funding soon so that we can meet again and continue our important work. But if you have ideas, give us send an email about ideas for other webinars. So thank you so much, everyone, and have a nice evening. Bye-bye.
Bye.
Thank you. Bye, everybody.
Bye-bye.
Bye.